Hey everyone. So, for today's AMA, we have Dr. Burstein, who got his bachelor's degree of psychology from the University of Pennsylvania and his master's and PhD degree from Nova Southeastern University. His training has primarily been in the techniques of behavioral and cognitive behavioral therapy with a focus on rational emotive behavior therapy. He's worked in a variety of settings, including hospital psychiatric units, outpatient clinics, and nursing homes. His clinical experience includes working with adults and children with a variety of behavioral health issues, but primarily has worked with helping parents develop effective strategies for children diagnosed with ADHD, Oppositional Defiant Disorder, and other behavior problems, and adults with anxiety, panic, and depression. Like I said, I'd like to focus more on live questions, but in lieu of that, we'll start with those on the AMA sheet. Real quickly, I'm going to share that in the presentation den if anyone wants to see the questions, and I guess we'll jump right into it. So, Dr. Burstein, question number 1. What exactly is psychotherapy?
Well, psychotherapy is the use of psychological techniques and research in order to help people to make changes in their lives, hopefully positive changes, to address issues that they are concerned about or that are impairing their functioning.
Alright, and what are some important features that you think any kind of psychotherapy should have?
Well, it's important, of course, for the psychotherapist to be able to listen to the individual. I think it's important for a therapist to have some kind of therapeutic philosophy or technique. One of the things that I use is Rational Emotive Behavior Therapy. There are psychoanalysts, there are people who do interpersonal therapies and all sorts of therapies, and usually it's helpful to have some kind of research-based background that you use to guide your techniques and to help the individual.
Okay. Um, Guys, let's not change the questions around, especially while we're doing this. So I'm going to revert to it in another version. Sorry. How did you decide this line of work was what you wanted to do?
Well, I was a lucky person who sort of figured out what they wanted to do early in life. I guess I took my first psychology course in high school, and I really enjoyed it, and thought that that was something that I would like to do. And then, like many new students, enrolled in the psychology courses in high school. At least when I went to school, I think psychology was the #2 major. And I really enjoyed my classes, the things that I learned there, and I decided that I would become a clinical psychologist and get my PhD.
In your own words, how would you define what clinical psychology is about specifically?
Well, that is essentially the application of psychological principles to helping people to make positive changes in their lives. So it's using the things that we learn as psychologists in research and applying it in ways that help people to bring about the change that they want.
And have you encountered any negative opinions about therapy? And if so, how have you responded to them?
Um, I don't try to convince anybody that they need to have therapy or believe in it. If people want to make changes through psychology, I'm happy to help them do that. But it's not for everybody, and if somebody doesn't believe in it or doesn't want to participate in it, then I don't make a lot of effort to change their minds. I don't really have a reason to do that.
Okay, right. Might have an interesting time listening to our discussion with Dr. Tenney. Um, what is your opinion of the American Psychological Association's efforts to codify a list of empirically supported treatments?
I think that's a great idea. One of the issues that we have not only in psychotherapy but in medicine in general is that very often people try things based on tradition or ways that they might have been taught that are now outmoded or found to be not very helpful. So I think it's a great effort. It's really difficult though because there are so many variables involved in measuring what's successful. Is it just the person saying they're better? Is it measures of behaviors that they're doing? So I think in practice it's pretty complicated, but having a therapy that's been proven by research to work seems to me to be a lot better idea than having something that we believe might work, but we really don't have the data to back it up.
And by that, or pursuant to that, by one estimate, there are over 500 types of psychotherapies. Do you think that there is some degree of redundancy in therapeutic modalities available?
Absolutely. If you kind of look at a lot of the different schools of thought in psychology, there are a lot of similarities. People may call things by different names. I do think that there is a lot of redundancy, but that being said, everybody has each psychologist, just as their clients, has their own personality, their own strengths and weaknesses, and some people work better using one modality than another, and they're more effective using that. So, I think it's okay that those various or many types of therapies are involved or around and redundant. It doesn't mean that they're not helpful, especially in the right hands.
How long does it take to perform an intake assessment for a new client coming in?
Um, if somebody is just coming in to seek some personal change, you can usually do an assessment in 1 to 2 sessions, sometimes longer. It really depends on the problem, but for most people, I think clinicians can develop a treatment plan within 1 to 2 sessions, and then it gets modified as you go along, as you might learn new things and understand the problem differently.
Do you have any strategies you use for establishing a therapeutic alliance with your clients?
I try to listen to them. I try to show understanding to their problems. I try to help them to see that their problems, even though to them are unique and distressing, that they're not alone. Other people have suffered the same thing, and that there's a way to improve the problem, make their lives better.
Okay. And what is cognitive behavioral therapy?
Cognitive behavioral therapy is therapy that acknowledges that ways people think have an important influence on the way that they feel, on their emotions, and that very often, in addition to changing or modifying some of their thoughts, it's important to change or modify some of their behaviors. So, it's kind of all in the name. So we use those ideas to help them to achieve their therapeutic goals.
Okay. And do you think that the cognitive part of CBT is more important or the behavioral part?
Uh, it depends on the individual. It's not something where for everybody the cognitive part is more important, or for everyone the behavioral part is more important. It depends on the problem, the person, what's going on with them, and that determines which is more important to work on at first or to put emphasis on.
Right. Because there's an article that's kind of thrown around here that purports that the heavy duty of CBT is mostly the behavioral component, but We'll leave that between you and Stephen Hayes. Um, what is rational emotive behavior therapy?
Well, rational emotive behavior therapy is a uh, subset of cognitive behavior therapy, essentially, and it focuses on particular ways that people think that tend to get in the way of their lives, and particularly in terms of what REBT therapists call more rigid ideas. And there are, um, uh, I guess, a good way to describe it, a way that I describe it for my clients is for everything that happens to us in life, there is a consequence in terms of how we feel, our emotional reaction to it. Sometimes that consequence is really minor and we're not aware of it. Sometimes it's really major and we're very aware of it. And other times it's somewhere in between. But if you think about anything that's happened to you over the course of your life, you can probably imagine somebody else experiencing that event differently from an emotional perspective than you did. And many times people have actually have had that experience where somebody felt the opposite of what they felt in a situation, or perhaps the same emotion but to a stronger or lesser degree. And what comes between the things that happen to us in life and the consequences in terms of our behaviors are our beliefs about ourselves and the world. And those beliefs are the basis of REBT, um, because uh, when those beliefs are too rigid, people experience things more intensely from an emotional perspective than when their flexible rules get bent. And that's important because when we have strong emotions, we tend to do things that are counterproductive. So when we're angry, we lash out. When we're anxious, we run away. Even sometimes good emotions, people get really happy and they do things that are counterproductive. So the essence of REBT is learning to identify particular cognitions that people have that are too rigid and making them more flexible through a process called disputing so that they can think more effectively and essentially modulate their emotions so that they can use their brains, their intellectual side to solve problems rather than trying to do it from an emotional perspective.
Okay.
That's REBT in a nutshell.
Who was Albert Ellis and what was his role in the history of psychotherapy?
Albert Ellis was the father of REBT. So he's the one who took the ideas of cognitive therapy in general and came up with this rational emotive behavior therapy. Initially, it was called Rational Emotive Therapy. Then he added the behavioral part, acknowledging the importance of behavior. And he wrote many books and papers. He wrote many books for uh, the general public. You can still find a lot of them, and they're still very important, helpful works.
Okay. Has REBT changed over time such that its tenets today are different from those that they used to be?
Um, yeah, as I said, it went from rational emotive therapy to rational emotive behavior therapy. And as with any living science and therapy, people do research, they learn things that can change some of the things that people do. We learn that things that we thought were effective really aren't. And there are new techniques to be used that can be effective.
Do you feel that REBT is simplified version of CBT?
Uh, no, I think that it is a version of cognitive behavioral therapy, um, but I wouldn't say that it's a simplified version. It's just different.
Okay. How do you feel about comparing REBT and CBT? In which situations or scenarios would it be more appropriate to use one over the other?
Well, again, REBT is a form of cognitive behavior therapy. So, you're always using cognitive behavior therapy as part of rational emotive behavior therapy. But there are other versions of cognitive behavioral therapy that people use. A lot of psychologists don't specifically say they're an REBT therapist. They just say that they're a cognitive behavioral therapist. Sometimes they bring in techniques from more behavioral areas or other schools of thought and cognition. But for the most part, I think as people work with clients, they're become more similar than different.
Okay. Do you think the broader societal culture can hinder the effectiveness of CBT?
I'm not sure exactly what that question is. I think that certainly if in society people have a negative view of therapy in general, then it makes people less willing to undergo it. But I'm not sure that there's a particular uh, societal hindrance that I'm aware of in the course of my practice where I think, oh, that makes it harder to do CBT.
Okay. Do you think the client's cultural background can hinder the effectiveness of CBT?
Culture is always important. CBT and REBT to a large, well, to both of them for the most part were developed in the United States, and it's possible that there is some cultural bias there. Um, in my personal experience, I haven't found that to be a big issue in general, but there's always going to be specific ideas that might be more uh, uh, prevalent in one culture than another that you might have to deal with. And there are some ideas that someone has who, as a therapist, you might believe that it's probably not in their best interest, but it's their culture and they may not want to change that particular way of thinking. So we have to do our best to help them um, in the context of those ideas.
Is there a role for cultural competency in your psychotherapeutic practice?
I think there's a role in everyone's. I think it's important to know one's limits, to understand that you may be working with somebody who um, might have ideas that are just not going to mesh with the way that you do therapy. And to help them to either find someone who has a better understanding of particular issues that may be relevant to them, or if you're motivated to do the homework to learn what those cultural issues are and how to address them.
Okay. How do you handle clients who are not native English speakers?
Well, if I can't communicate with somebody, then it's difficult for me to be effective as a therapist, and I would try to get them help in finding someone who is able to speak to them. Psychotherapy in general is talk therapy. So if it's difficult for you and the client to understand each other, it's a big barrier to effective treatment. And that doesn't mean it can't be overcome, but it might be more efficient to help them to find someone who has the knowledge and experience to provide better service than I might be able to do if I don't speak their language.
What kind of client problems do you frequently encounter in your practice?
Well, I tend to work with people who have anxiety and or panic attacks. I enjoy working with people who are depressed or just having difficulty functioning in one way or another, and very often because of those rigid rules that they have. Um, So, but in terms of children, adults, or the elderly, for me personally, I find that adolescents are the most challenging to work with, but I have many colleagues who that's their favorite clients. So again, we have to focus on where we're most effective, that suits our personalities and our styles.
Okay. In recent years, CBT has gained a reputation for gaslighting the clients and patients. How true do you think that is? And if true, how has the criticism been addressed to mitigate these effects?
Um, I have not really heard about that, so I'm not sure what it means. So I'm going to defer on that particular question.
Okay. Oppositional defiant disorder usually shows up in teenagers, from what I understand. How is it addressed using the CBT REBT modality?
Well, in my experience, oppositional defiant disorder can occur very early in life. It doesn't necessarily show up in teenagers. I think it's particularly difficult to deal with in teenagers because they're at a time in their life developmentally when they may not necessarily be interested in change. It's a time when it's very difficult for them to understand the world in the way that they may when they are older, and to have the same motivations to make changes. But again, I'm not that's not my preference to work with teenagers. When I work with children, I try to work with their parents in terms of giving them the kinds of tools that they need to overcome oppositional defiant disorder, helping them to see where their power does and doesn't lie so that they can motivate their child and to circumvent that oppositional defiant types of behaviors and attitudes. Because if you try to push against them, they're going to dig in their heels and do their best to uh, get their way, essentially, or at least not let you get your way. So when you learn how to motivate the children with oppositional defiant disorder and circumvent those that type of behavior, it's very effective. And we use things like token economies and other ways that parents can help to motivate their children to work towards positive things rather than to avoid punishments and things like that, which tend to backfire in the long run.
Okay. Um, so we have a live question, so I'm going to prioritize those. In the
Okay.
chat, Kid Sees Ghost says, "What are some things you wish you knew or were taught early in your career?"
I think that the biggest thing that helped me was becoming a parent. um, someone who worked with a lot of kids and parents um, before I had children. It's a lot easier to think that things are easy to do. I think having that experience helped me to grow as a person and to grow as a therapist as I kind of got more realistic about what those things were like, just as being in a marriage and having other life experiences, I think helped to augment my clinical training in terms of being a therapist and, as I said, growing as a person.
All right. Children have trouble with metacognition, from my experience. Have you ever experienced issues when working with children for metacognition, and if so, how have you addressed the issues?
Um, that's another type of therapy that I'm really not familiar with. Um, Again, when I worked with children, I mostly do parent training and helping their parents learn better ways to manage their behaviors. So more of a behavior therapist with children rather than working directly with them.
Okay. Benzene, I think. asks, does your professional life take a toll on your personal life sometimes in terms of being invested in the client and their progress?
I think part of being a professional is learning how to distance yourself so that when you close the door on your office, you close the door on your cases. But once in a while, there's an issue that's really interesting or challenging, and yeah, I spend a little bit more time thinking about how I'm going to handle it. But eventually, I learned how to again drop that off when I go home. But sometimes, especially at the height of my career, it's long hours. Then just seeing a lot of people. I think there's a question later about insurance and reimbursement, where you sometimes have to work long hours to pay your bills. That gets in the way.
Okay, also just a note to the audience. So like I said, I'm prioritizing live questions. You can write in the presentation den, or if you raise your hand in the AMA stage, you can come up and ask live with your voice. Anyway, moving forward. How do you manage post-operative delirium or hospital-acquired delirium with your patients?
Well, I don't, and I would tend to let psychiatrists handle that. Um, those people are when somebody is delirious, they're usually not in a place to do psychotherapy. But that's not a population that I work with.
Okay. Fritz asks, do you have much correspondence with psychiatrists? If so, what might require that correspondence?
Um, when I work with somebody who is seeing a psychiatrist and I'm concerned about the medication that they're getting, if I'm not clear that the psychiatrist is understanding the issues, or there's some other issue that calls for working together, then I would contact the psychiatrist involved. Unfortunately, the way that clinical practice works now, we're usually in our own separate silos, and we don't get to speak very often. But there are times when it's clear to me or to the psychiatrist that there needs to be some coordination. One of the problems that psychiatrists run into is very often they're limited to very brief visits with the person. So they may not have an opportunity to do as full an assessment and have as full an understanding as they would like. So that's where coordination is helpful.
Okay. Ridley97 asks, do you find there are limitations to CBT, and if so, what might they be?
Well, the limitations would chiefly be when somebody has an issue that you've just it might be really more appropriate for medication management, such as delirium. That's not a situation where the person's beliefs or cognitions are going to really be a factor if they're unable to put thoughts together. So that would be a big area of limitation.
Okay. Ciderbeck asks, does your practice acknowledge the role of systemic disempowerment as a factor in mental health distress? Does it acknowledge that some barriers aren't cognitive at all and are instead issues of economic, social, and political oppression?
Well, of course. There are people have very real issues related to very real problems that are going on in their lives. So, but it's not so much about solving societal issues, which is a pretty ambitious goal for a psychotherapy relationship. But what you can do in psychotherapy is help the person to cope in a more productive way with those issues that are going on around them.
Okay. How can nurses integrate CBT and REBT concepts into their own practice?
It depends on what their practice is. If typically nurses are not doing psychotherapy. More and more often, there are nurses who are managing medications, especially nurses with advanced degrees in nursing. Um, so they can sometimes do psychotherapy as part of that, but very often they don't have enough time to do that. What I have found very often is that when people don't have deep experience into something, as a practitioner, then it's easy to overlook things or to get lost in things or not to do an effective job. So um, unless a nurse is really uh, wanting to focus on being a therapist and getting the training to do that, I'm not sure that a little bit of knowledge of those things can be very helpful.
Okay. Have you had mostly good or bad experience collaborating with psychiatrists?
Mostly good. I think that a lot of people um, want to think that there's some war going on between psychiatrists and psychologists, and I have not found that to be true in my career. We've always been able to collaborate as a team when necessary. Um, I've always felt that they listen to my opinions. I've listened to theirs. So for the most part, my experiences has been very good. And the bad experiences has been with people who were just not nice people for one reason or another. It's not the fact that they're a psychiatrist.
Um, do you think nursing homes in the U.S. are well equipped to handle patients with mental illnesses?
Not so much, although more and more they are having psychologists come in as consultants, and that's very helpful, especially when the staff is made available to get training and to work with the psychologist and or psychiatrist on what's going on with a particular person and coming up with a plan that they may implement that might help them to address problematic behaviors.
Okay. In recent or Zinc, I think, as in recent years, there's been a lot of glamorization of psychology, with psychologists like Jordan Peterson given celebrity treatment. What do you think about this? Is this helpful or does it lead to issues?
I'm not a big fan. I think that sometimes what happens is they make it look way easier, or that they make it look like psychologists or psychiatrists just know it all, and you tell them a problem and they've got the solution, and that's it. Uh, that's not therapy. You know, therapy is a process where you identify problems, you help the person to um, develop strategies for overcoming them, to question their cognitions, to learn new behaviors. You can't do that in the course of a 30 or 40-minute time that most media psychologists have in terms of their programs, especially on TV. And again, you're just hearing uh, a little bit of the problem and coming up with a solution that sounds great, but probably is not going to work for very long, except for the simplest of problems.
Okay. Do parents get in the way of your working or work involving children, or are they more helpful as partners in care?
Well, it depends on the parent. I've worked with parents who are unwilling to change their behaviors, unwilling to say no to their children, or allow their children to be in any distress, and that makes it difficult for their children to learn how to change their behaviors or to deal with distress, and that happens a lot working with those oppositional defiant kids. So in that case, they can be a hindrance. But for the most part, the parents that I've worked with have wanted to help their children. They've listened and done their best to implement the things that we have agreed on, and it's been very effective.
Okay. What has been your experience interacting with insurance companies for reimbursement, if you do that at all?
Well, I don't do it directly. It's usually done by the practices that I'm working under. But for the most part, reimbursement for psychologists is not great for the amount of time and effort one has to put to, especially get a doctoral degree. Um, I think that many years ago, psychologists had the mistaken notion that the way to gain legitimacy was to be recognized by insurance companies and to get reimbursement. And they did that, and then managed care came in. And the whole idea of managed care is to be able to control the cost of health care, including mental health care, which they sort of carved out as this separate thing, different somehow from general medical care. And many companies, really cut the reimbursement to a degree where, it barely pays for the time that you have, your expenses. So it has overall not been a positive experience, and that's why throughout my career I've used my degree in other ways that have helped me to make a better living.
Okay. Just a note, Fritz, he did answer that question, and like I said, if you write it in the chat, I'm gonna prioritize it. Shine asks, can apply studying psychology in other areas of your life, very specifically a career in management? Like, how would it benefit someone who won't go into traditional psychology fields and take it up as a hobby? So I think they're asking, is learning psychology useful for lay people, even if they're not going to practice, if I'm understanding that?
Well, I think for most people it would be helpful in learning ways to make your own life better. That's why all those self-help books are out there. And depending on the issue, sometimes those things can be very helpful. But as human beings, it's difficult for us to look inward sometimes and recognize some of the patterns and things that we do that may be a mistake. And that's where it's helpful to see a therapist. But to be like Lucy in the Peanuts comic strip and set up your own psychotherapy booth for 5 cents or whatever you want to charge, I'm not sure that would be helpful to people, but it can certainly help if you're a manager. Maybe some of those techniques can help you to learn to be a more effective manager in dealing with relations with people, or sometimes to deal with difficult people.
Okay. Do you pay attention to updates to the DSM, or is the DSM not something you pay attention to?
Well, for me personally, it's not something that I pay a lot of attention to. I deal with the diagnoses that I work with, and the fine points are not really that important to me in terms of understanding problems. I think that the DSM is a way to codify and certain types of pathology, which is helpful in getting reimbursed, but it's not always really helpful in terms of actually helping somebody, and that's really my focus.
All right. Benzine asks, do you think sometimes a client's own skepticism for therapy hinders their treatment to a great degree? And if so, what do you do to deal with it?
Well, if somebody is coming to me and saying, "Well, I don't think you can help me. I'm doing this because my wife, husband, significant other, children told me to do this," that could be very difficult to get around. But sometimes, in the course of speaking to someone, you get kind of an in terms of joining with them. and saying, well, I understand who you might feel that way. Um, Here's something that people that I've worked with have found helpful, or perhaps if we look at from this way, we can make a difference in your life. So and I guess to a better way to say it is that rather than saying, well, you have a problem that you have to fix, in terms of there's something wrong with your character or personality, it's more of, well, this is an issue going on in your life. It's perfectly understandable that you would have it. Let's talk about ways we can make the issue better rather than fix you as a person.
Okay. Is there much of a difference between PhD programs in clinical psychology and PsyD programs in the US?
Not so much anymore. I think maybe there was a time when there was a difference. I think that for most people, the difference is that in a PhD program, there's going to be more of an emphasis on doing an original piece of research, a doctoral dissertation. Whereas in a PsyD program, there's a little bit more of a clinical emphasis, and their doctoral paper can be a literature study. They don't necessarily have to do an original piece of research. But aside from that particular area, for the most part, the training is very similar. And when I was in school, we took classes. I was in the PhD program. We took classes with the PsyD students. I was a TA in the PsyD program for statistics. So I think there's a lot of intermixing. Sometimes it's certainly possible that there is a different emphasis in a particular program that would depend on the college or university. And PhD students also would tend to branch into areas beyond clinical psychology. So they may go into psychophysiology or experimental psychology, or things that might eventually filter down to clinical psychology, but are different areas of study.
Okay. Is diet and nutrition something important to go over with patients suffering from anxiety or depression?
Um, Only as, in my opinion, as a matter of general health. Um, Sometimes people, especially who suffer from anxiety, can have superstitious-like beliefs that they should avoid certain things like coffee or alcohol or particular kinds of foods, because they believe that somehow that affects their anxiety or causes panic attacks, and that there's just no clinical evidence from that. But of course, in general, when we eat healthier, when we take care of ourselves better, we can tend to feel better and have less illness. But for me personally, it's not a major part of psychology, my psychology practice.
Do you think the movement to grant clinical psychologists prescription privileges is misguided or a good idea?
I think that there are places in the country where there is very few psychiatrists. So in certain areas, in certain situations, it's better than nothing. But as a psychologist, at least when I went to school, there was not a lot of emphasis on those types of things. And prescribing medication involves knowledge about body chemistry. There are all sorts of issues involved in interactions with other medications and how these things work, that psychologists don't necessarily receive a lot of training on. And the training that they get is going to be less extensive than a psychiatrist. But again, if the problem is relatively uncomplicated, if there's not a lot of psychiatric support in the area, it may be helpful for a psychiatrist or a psychologist rather to have those privileges. For me personally, it's not something that I want to get involved in, but I live in an area where there's a good number of psychiatrists, so it's not really an issue that I feel compelled in order to help people.
Has it resulted in more confusion or more clarity that ADD has been subsumed under ADHD?
Uh, in my opinion, it's more clarity. Uh, the thinking and the research is showing that it's more part of the same uh, syndrome, and changing it to ADD, or just dealing with the attention deficit part is not necessarily as effective, and those people who just have trouble paying attention may not truly have the same level of pathology. Um, but again, I think it's an issue where we get focused on the label rather than what's the issue, how can we help this person.
Okay, Zig asks, a lot of therapists consider childhood trauma to be a vital part of gauging a client's situation. When going about this, how do you prevent it from becoming painful for the client? And what is your general advice for the layperson trying to heal from their trauma?
Well, you know, for the most part, as a psychologist, we try to set an environment where somebody feels comfortable talking about their issues. And sometimes it takes a while before they feel ready to do that. So I think it's again helping the person to get to a place where they may be wanting to deal with that trauma, or sometimes, again, depending on the trauma, the situation, to maybe get away from focusing on the trauma and to using that to learn more effective ways of dealing with life, different behaviors, different ways of thinking about things, and not necessarily going through and remembering what happened to them and dealing with it right away if it's their preference not to relive that pain.
Okay. A question I have, and some colleagues and I were discussing this. What do you think are the boundaries of trauma, or how do we decide what is and isn't trauma?
That's a great question, and it's one that I deal with as part of another job that I have in uh, as a medical consultant for an insurance company. And I think as a therapist, um, part of it is accepting if somebody feels that they were traumatized in some way. I don't see any positive, any benefit in trying to convince them that they weren't traumatized. Um, but what is effective is helping them to put that trauma into some kind of context where they can learn from it, make their lives better, learn how to move on from that trauma. So if somebody feels, for example, that they were in a toxic work environment where many people around them may be just fine in that environment, but it's bad for them, then helping them to develop better coping skills in order to deal with that, and helping them to see that as a problem in their life, but not something that necessarily needs to stop them or impair their functioning.
All right. Ridley97 asks, have you come across reactive attachment disorder much in your treatment of children or younger clients? How has it affected your ability to establish the therapeutic relationship and address potential trauma if said client has difficulty with attachment?
No, I haven't had a lot of clinical experience with that in practice. When I was in school, I had the privilege of studying under a professor, and I'm sorry, I can't recall his name offhand, but who was actually really involved in that whole reactive attachment disorder system and doing family therapy, and he had an institute in Colorado, and it was all fascinating, but it's not all that common, and it's just not something that I had to deal with in practice as a therapist.
Do you dislike it when people call depression the common cold of mental illness?
I have not heard that expression, and I'm not sure what difference it makes. Again, I don't know that that somehow um, it attempts to make depression less of a something that's important in some way. I think that a lot of people have different issues adjusting to problems in their lives, and sometimes they get depressed about it, sometimes they get anxious about it. Ultimately, for me, it's about teaching them coping skills to learn how to deal with it.
What has been your experience working with allied professions such as behavior analysts and pediatricians?
It's been pretty positive. I try to keep an open mind about working with other fields, and certainly, I studied a lot of behavioral theories when I was a student, and I employ a lot of them as a therapist. So I would not, I have not actually had much opportunity to work with applied behavioral analysts, but I would certainly welcome the chance to do so. I've worked with many pediatricians in terms of, helping them decide whether or not they want to prescribe medication. But typically, I would encourage pediatricians to try to enlist or refer to a psychiatrist who has more experience in dealing with psychotropic medications. Very often, generalists, in an effort not to do harm, underprescribe. So the problem is that you're potentially at risk for the side effects of a medication, but not necessarily having a large enough dose to get the benefit from it.
Do you have a preference for working with inpatient versus outpatient settings?
Um, I was primarily an outpatient therapist and am, and I guess that's my preference. But it's very often a matter of that people in inpatient settings are undergoing a crisis. They don't necessarily have tougher or bigger problems. Sometimes they do, but sometimes they again need the aid of medication in order to help them to regulate their emotions. But I've generally been an outpatient therapist, except for brief stints here or there early in my career.
If you could change one thing about the clinical psychologist community, what would it be?
Uh, for me and my colleagues to be as evidence-based and scientifically based as possible. I think sometimes, um, you know, people have ideas that sort of become fad theories that have a lot of potential but have not necessarily been proven. Sometimes psychologists, like physicians and lay people, accept things and beliefs that just really have no research basis behind them, and I think that uh, can encourage counter-therapeutic recommendations that just don't help people.
Have you had child clients who have gotten involved with the criminal justice system?
No, I haven't really worked with that population very much.
All right. Would you recommend to aspiring therapists to learn more than one modality?
Absolutely. I think that by opening yourself up to different modalities is how you learn which one can works for you, that is most effective for you as a therapist to employ. Early in my career, I was in a very, well, as a student in a very behaviorally based program. And as much as I enjoyed it, I didn't think that it addressed every possible problem that a person can have, and that's where I started to learn more about cognitive behavioral therapies. So I think learning about and opening up to different types of therapies are important, especially as a student, because you have not had the very deep exposure to some of these modalities, and you may find that the reality is not quite as good as the idea.
How are family members involved in client care typically?
In my experience, they're involved when I'm working with children and we have to work with their parents, or in couples therapy. But that's me and the way I do therapy. I know other um, psychologists or therapists that I know like to bring in other family members to get their perspectives on things. Sometimes that is helpful. I've done it, but rarely. Um, but again, it depends on the case and the psychologist.
Um, when would you be required to disclose psychotherapy notes to an outside party?
Um, well, it there are certain situations in terms of notes. Very rarely, you may submit them to the to an insurance company for reimbursement and quality management purposes, but there you can sort of maintain two books where you have personal things that people talk about and say, which is private, and more general symptoms and modalities that you're using to address those symptoms. But it's pretty rare that the specific things that a person says are things that you would or would be mandated to disclose to an outside party, certainly without a court order.
Benzine asks, are there any general resources, such as books or videos, from which anyone can learn basics of psychology? What are they, and to what extent will they be helpful?
Um, there are lots of introductory psychology textbooks that can give you an overview of psychology schools of thought and different types of therapies and their history. There are once you learn about that, then you can start to read the works of some of the psychologists and other professionals who have pioneered those schools of thought and written about them, and the people who learn from them. Uh, but it's so varied that it would be hard to recommend a particular source. But probably a good one would be to check out an introductory psychology textbook and take it from there.
Boofluff asks, do you know Dr. K?
First name?
Okay, so I think he's referring to the Twitch streamer Dr. K. Yes, Healthy Gamer GG.
No.
Yeah. Uh, Ridley97 asks, have you found that there is a sort of triage of symptoms, behaviors, issues that have to be addressed before others? For instance, a client with substance abuse issues might need to address or begin sobriety work before having the capability to address further issues.
Well, absolutely. That's part of the assessment process where, it's certainly pretty common that people have multiple issues going on in their lives. Sometimes they have depression and panic attacks. Sometimes they have substance abuse problems. So it's important to see which is having the greatest effect and or which would be most appropriate to address first in order to get to the others. So it's really specific to the client that you're working with. So there's no rule of thumb that you've got to do it this way or it doesn't work.
Are you worried that child clients with behavioral problems who go to school might not get sufficient accommodations?
Um, sure. I think that sadly that's more common than anybody would like to see. It's in part because schools are not necessarily therapeutic environments. Teachers don't necessarily have the training or understanding to deal with every problem that a child may have, and very often schools are extremely underfunded. So you know, these children may have a particular need that is just not going to be addressed there. Sometimes parents have to take them to schools that specialize in dealing with a problem.
All right. How can you quickly tell if a new client would be better served being referred to a different type of provider?
Um, well, sometimes people have an issue that I don't have a lot of knowledge or experience. You know, I'm not a substance abuse therapist. So if that's the major issue for a person, I would refer them out. As I said, I would, I usually don't take on adolescent clients, just not my thing. Um, and there's probably a bunch of things. If I don't feel qualified for a handling a problem, then I will refer that person out. I don't do sex therapy, so if that's the issue, I would refer them. I don't do eating disorders. So I think as a therapist, it's important to know your limits. And if you don't have experience in training and dealing with the problem, and nobody can handle everything. It's important to know when to refer that person to somebody else.
All right. To the previous question about teachers,
Mhm.
Fritz asks, should teachers be trained better in dealing with mental illnesses?
Well, should they? That's one of those REB rigid demands that I was talking about earlier. When we say should, that implies that's it's a yes or no answer. I think it would be nice if teachers have that training. But again, they have a limited time to be trained. Not everybody can learn everything, and it's not their primary job. So I think it's important for them to have some understanding of psychology and how to motivate their students. But I don't think it's realistic that all teachers can have a deep understanding and act as therapists.
Okay. Zink asks, has your psychology background and expertise help you personally in setting, for example, getting out of parties and manipulation tactics?
Um, I think that it's helped me to grow as a person and to it's helped me to understand some situations better. I don't know that it perhaps makes me a little less vulnerable to being scammed, but I don't profess to having a special power in that area.
Okay. What would you say is the biggest lessons learned from looking at the history of change in psychotherapies?
Well, it's um, the lesson of science is that we start from what we know, and then we do experiments. We put forth hypotheses, we test them, and as we learn what is uh, helpful, as we learn the data, then we become better at learning about people and how to help them. Just as science progresses, where they start with maybe not knowing a lot about a particular subject, and they put forth theories, ideas, try to prove and disprove them, and through that develop effective ways to handle problems. It's all the scientific method.
What would you say? Oops, next question. Have you ever had clients with antisocial personality disorder?
Um, Probably, but it was not the focus of therapy. And people with antisocial personality disorder either don't come into therapy because they don't think that they need it, or they're there because they've been mandated to be there, and that's not my first choice of client. I prefer people who are coming in voluntarily, so that's one of those that I might refer to someone with more experience in that. Um, but again, for the most part, um, they don't come in voluntarily to stop being antisocial.
Um, do you use person first language?
In terms of being sensitive to people's gender identities, or
No, so I think this is in reference to, so for example, in the autism community, person first language would be like person with autism versus identity first, which would be autistic person. So when you're talking about clients, would you refer to them like individual with depression or a depressed individual or some other way?
um, I would tend to talk about them as a person who has an issue in their life that they would like to deal with. So I tend to avoid labeling people. And again, that goes back to the question about diagnosis. This is, I'm not dealing with a depression or a panic disorder. I'm dealing with a person who has an issue in their life that they want to change. So I guess the answer to that would be yes.
Ridley 97 asks, do you think there is either a population of people and or a subset of clinical psychology that has been neglected in research, and so therefore treatment methods and approaches are more limited?
Um, I think that there are people, there are issues that are not very common. So they're not recognized. I can't think of any offhand, but I'm sure that there are. But if somebody is interested in a particular problem, that's an opportunity to do research and learn about it. When I was going to school, it was long enough ago that ADHD was just starting to become part of the mainstream, and as well as autism. I had a classmate who had an autistic child, and she sort of made that her focus of study because there wasn't a lot out there. Uh, so sometimes we don't recognize problems for a while, and then we learn to distinguish them from other problems, and that's where they start to get more attention. Um,
All
so
right.
I guess I've run out of gas on that one.
Okay. What advice would you give someone considering clinical psychology as a career?
Run away. um, I try to find out what the person is really interested in, because in today's world, and going back to things like insurance reimbursement, et cetera, if somebody just wants to do therapy, they don't want to do research, they don't want to teach, then I would recommend that they consider a course in counseling, psychology, or as a master's level therapist, and there are different versions of that depending on what somebody is interested in. Um, the reimbursement is very often not very different, and if that's what they want to do, you can always spend your lifetime learning and getting more of that knowledge. But there are some things that you just need a doctorate in order to do. And if you're interested in doing those kinds of things, such as teaching at a university level, uh, doing research, then it's helpful to get that doctoral degree. But in many ways, I think the general public doesn't make that distinction. So if you want to do therapy, I don't know that the public often makes a distinction between I'm seeing a master's level therapist versus a doctoral level therapist.
Okay. Can a person learn the basics of psychology, especially nonverbals, through reading books and watching videos with people such as former counterintelligence agent Joe Navarro?
Well, I'm not familiar with former counterintelligence agent Joe Navarro, but sure, people can learn anything by studying, reading books, watching videos. Um, it helps though to work academically because there's a lot of people out there who put themselves out as experts when they don't really have that expertise, where they really haven't done the research that would be required. And especially they haven't published research in a way that's been reviewed by peers and criticized through the scientific process that helps to weed out ideas that sound good but really don't have much validity in life to those that actually do have validity. And sometimes those ideas can be counterintuitive. So if you're interested in it, I always encourage people to learn more, but it's important to understand who's writing the book, who's making the video. Do they have an axe to grind? Are they trying to sell something? Or have they really learned something new? Or are they conveying something that is, has been vetted through the psychological academia?
Boofluff asks, do you have any advice for handling academic pressure or stress, but also performing well throughout undergrad, graduate, or postgraduate?
Well, it's in REBT, we would talk about making the demands that you have to be perfect, you have to get everything right, you have to be at the top of your class. You can't ever have less than an A. Those are ideas that, if you don't think about it, sounds like good ideas, but they're not always possible for every single person. Everybody can't be above average, or they wouldn't. There would be no average. So. Learning to be less demanding of one's performance helps one to relax, think more clearly, and be more successful than making demands that you be perfect as a student. So it's learning to change those ideas, but realize the importance of working hard and getting good grades, and also to realize that those things don't necessarily define you as a person. Somebody a straight A student is not a more valuable human being than an F student. They just have more opportunities based on that particular measurement.
Benzine asks, when dealing with patients who have family-induced trauma and are living with them, how do you help them? Additionally, what is your experience with people coming from abusive households?
Well, I'm not a big trauma therapist, so I don't often deal with that. So if somebody is really experiencing significant issues with trauma, I would refer them to a therapist who handles that more regularly. But for less serious issues where it is more manageable for them, then I help them to develop realistic ideas about themselves and the people in their lives, so that they learn how to not accept in the sense of like, but accept the fact that this person is going to behave in this particular way no matter what you do. So what's some ways that you can adjust your way of thinking about this, your behaviors, that makes the situation work out better for you?
All right. Besides therapy and counseling, what careers are available for someone going down the clinical psychology route?
Well, chiefly that would be doing research about therapeutic techniques and tools for psychologists to use to help people. But I think that perhaps questioner is stuck on the clinical part, because clinical is the application of psychological principles and ideas to helping people. But there's in industrial organizational psychology, which is more about helping businesses to uh, utilize techniques that help to motivate their workers better. There's psychophysiology, which is understanding how the brain perceives the environment, and learning about things like that. So that there's developmental psychology. How do people develop as intellectually, cognitively, emotionally, behaviorally, from children to adults. So there are many other branches of psychology that deal with the general issue of human behavior, but specific aspects of it.
How do you respond to marriage and couples conflict where divorce may involve and they have children?
Well, it depends on what their goal is. Is their goal to stay together and be a couple, or is their goal to split apart and learn how to work cooperatively as parents? My job is not to tell people this is how you should live your life. My job is to say, what is your goal? What do you want to accomplish? And assuming that it's not something that's harmful to them, to help them to achieve it. And if I think it's something that's going to get them into trouble or be harmful, I explain why and talk about ways that they may achieve something, whatever healthy part is in that goal that they have.
Okay. What is the difference between a clinical psychologist, behavior analyst, and behavior psychologist in their line of work?
In practice, not very much. They're using different techniques to achieve the same goal.
Okay. Do you think it's possible for a therapist who is single or childless to be effective when working with children?
Absolutely. It may be a little bit more difficult. I think there is, again, from my own personal experience, I think that there is an understanding of being a parent and the difficulties that one can have, that you don't really understand as well if you don't have children or are childless. But I don't have to be schizophrenic to work with a schizophrenic, or in panic to work with somebody who has panic attacks. So, I think that you can be effective, and again, it depends on the person, the problem, and how well you know the techniques.
Okay. Are there protocols for handling violent clients in session?
Yeah, keep you, facing them, and keep your back to the door so that you can get out in a hurry if you need to. And I'm sure there are lots of others. I don't deal with violent individuals, so it's not my area of expertise.
All right. Zink asks, hustle culture in its ever-increasing popularity is making people think of themselves as their achievements instead of a human being. How can such a person shed this rigid belief and regain enjoyment from life?
Great question, especially for an REBT therapist. So it's helping them to see that they have ideas that are not realistic, in the sense that they're defined by, they should achieve this, or they shouldn't do that. Where a demand in REBT is defined as an expectation that can either never be met or can't be met all the time, but the person's expectation is that it will always be that way. So if somebody has an idea that they have to be a millionaire by their 30, that's a tough thing to do, and it's okay as a goal. But if you're defining your life in that way and the chances your success is small, then you're setting yourself up to feel like a failure. And then the rest of your life is downhill from there versus learning how to cope with things not turning out the way that you want to and coming up with new plans and moving on with your life. So I think those ideas of you have to do something, and especially you have to do it by a certain deadline. If you don't think about it, sounds great. Who wouldn't want to be a millionaire by the time they're 30? But the reality is that it's extremely difficult to do. And so when you set that as a goal, you might achieve it, and if you don't, then you just change your goal. But if it's something that you have to do, then you're washed up at 30, and what are you going to do with the rest of your life? So, um, you know, making those rigid ideas more flexible would be key in helping that person to take the good part of hustle culture, to work hard, to set goals, to do your best to meet them, but then to have the ability to pick themselves up, dust themselves off, and move on when they don't achieve exactly what they wanted to.
Alright. Ridley97 asks, are there times when you find that therapy sessions are not productive? Perhaps there is a block with the client which they are not willing to address. And how do you address this? How might you go about telling them that sessions are not productive?
I don't know that it's helpful to do that. There are certainly days where a client is just not in the mood to work, or once in a while I'm having a bad day and I'm not as effective as I could be. But we persevere as best we can, and we get to it, get back to it at our next session. Kind of goes down to what I was just talking about, is that as much as we would like every session to be helpful and effective and the best it can be, that's not the way life works.
Alright. Um, Benzene asks, there are some people who have extremely political and vitriolic terms of their political alignment and the effect of which is then flowing into their daily life. What is your opinion on overcoming this divisive mindset? And then they said personal as well as from a psychologist's point of view.
Well, there's that old joke about how many psychologists to does it take to change a light bulb, and it's just one, but the light bulb has to want to change. So, if somebody is kind of hooked into their particular belief system, it's really difficult to get them to stop. There are, approaches that people use who work with cult members where there's kind of an intervention. But I'm certainly not skilled in that, and wouldn't even attempt it. But really, if a person is entrenched in an unhealthy belief system and they don't see it as unhealthy, it's very difficult to get them out of it. And sometimes we just have to accept them as they are, and try to make the best of our lives in spite of that.
Alright. I've heard that manualized therapies aren't favored by many people because they don't allow for flexibility in adapting to specific client needs. Do you agree?
Well, I think that's where manualized therapies in the hands of a trained professional can be extremely effective. I use that a particular program for my clients with panic disorder. So I think it helps to keep you focused on the issue that you're wanting to work on and adapt to. But having a professional who has a kind of greater understanding allows you to make modifications where needed so that it's helping this particular individual.
Okay. Are there certain psychodynamic concepts that are so broadly useful that therapists of all stripes can use them?
Well, Well, I think that, you know, s- psychodynamic therapies have a lot of good ideas about what motivates people, um, what might be important to them. Uh, and I think having that understanding in general as a psychologist helps you to have a broader understanding of how to employ techniques that may not be psychodynamic in the way we're using them. So, but I don't know of a particular concept in any area of psychology or life, for that matter. There aren't too many things that are true of everybody in every situation.
All right. Um, what is your approach when working with a person with persistent depressive symptoms primarily due to their way of thinking? How about life circumstances?
Well, that's what therapy is about, is helping people to understand ways of thinking that make it more difficult for them to adjust to life and to deal with whatever it is that they want to deal with in life, to be happier, to achieve their goals. So, that's really, again, the purpose of psychotherapy. Now, there are some people who, because of the biology of their particular brains, are just going to be more prone to being depressed no matter what they do. And there, it's really helping them to accept that reality. Again, not like it, but just understand that this is the reality, and to figure out ways to cope with it, even though their mood is bad, so that they don't get caught in a situation where their depression becomes even deeper than it needs to be, and their life more impaired than it needs to be.
Okay, quick note. If you're struggling with the Google Sheet, you can write your question in the presentation den, and it'll be asked there. Um, is it often unhelpful or helpful to dwell on the unconscious in therapy?
Well, as a cognitive behavior therapist, we don't really deal much with the unconscious, but there are certainly many psychodynamic uh, therapists who would say that you absolutely have to deal with that. But for me personally, no.
Okay, Ridley97 asks, are there times when you find it more beneficial to incorporate structured psychological testing? What are the advantages to these structured tests?
Well, I don't actually do it, but if you're in a forensic situation where you want to determine, for example, if somebody is a danger to themselves or others, they can be very helpful. If someone has had a head injury and we want to know what their limitations are, then neuropsychological testing can be very helpful. There are times when someone might have some kind of psychological disorder that is just really unclear, where an evaluation can help to uh, better understand some of the issues that are going on with the person, so that you can come up with a better treatment plan. But for the most part, I think that in practice, uh, if a psychologist or therapist is just wanting to help somebody deal with a problem, they're probably not going to do very much testing, if any at all. Aside, maybe there are many self-report inventories that can be used to help assess the ideas a person has of particular cognitions that might be problematic, and to just have them rate their mood, so you can see improvement in their mood or level of anxiety or something like that.
All right. What's the most rewarding part of your day-to-day work routine?
Well, it's always rewarding when you work with somebody and something clicks with them and they realize a better way that they can handle their lives through your therapy, and they feel better, and their lives are better.
All right. Um, is dissociative identity disorder real?
We don't really know. Um, there are a lot of psychologists and people who will swear up and down that it actually absolutely does exist. There are others who think that it's all made up. But I don't know that any definitive research has been done that can say that yes, it exists, or no, it doesn't. But whether it's real or not, many people have those sorts of issues, and sometimes there's a clinical sense they've endured some kind of trauma, and that's the only way that they have found to be able to cope with that trauma. And um, you know, the, you know, at least as a therapist, accepting that and working with it can help them to get better. But again, I think that the jury is still out on whether it really exists, or whether it's something that's generated by expectations of the person, or the therapist involved.
Zinc asks, for the creative person archetype who are constantly struggling with fitting in, what is your approach?
Well, why do you have to fit in? You know, there are, I think it's really about what would you like to go better, and maybe teaching them tools to do that, to interact with people in a more effective ways, but not necessarily changing who they are. But understanding, well, if you hang on to this is the cost, this is the benefit. So, you can act a certain way even though you don't believe it, or you can just say, I'm going to be who I am, and I'll accept the fact that some people aren't going to like that.
And then Zinc also asks, thoughts on individuation?
You have to be a little bit more specific on that.
Well, Zinc, if you want to elaborate, you're welcome to. Um, Alex Klein asks, has there ever been any situation where you got into your limitations as a therapist and got very emotional?
Not that I recall. Um, I work very hard at not getting emotional in therapy, because I'm there to help the person. They're not there to help me. It's not about me, it's about them. So, um, uh, keeping that focus, I don't believe I have. Uh, you know, but there have been, intense times that were, um, uh, I guess, uh, got me more emotionally up, but I think I was able to hold that in check, and get through the session and then deal with it afterwards.
Zinc
But not very
asks,
often.
or
Yep.
he followed up, he's referring to Jungian individuation.
I am not a Jungian, so I don't really think in those terms. Um, so I don't really have an opinion about it.
Alright, Boofluff asks, I heard that every therapist has their own therapist. Is that true?
No. Again, that's one of those rigid beliefs. I mean, therapists are people. Sometimes they have issues. Sometimes it's helpful to have therapy. But uh, I don't know that most, even, let alone all. I know that all don't have it. And again, that's part of Freudian therapies, is undergoing therapy yourself. So I think that's kind of specific to those types of psychodynamic therapies versus cognitive behavior therapies, where absolutely somebody, a therapist might go to another therapist for a problem, or if they think they need supervision, or help because they don't have experience dealing with a particular problem. But but not as a general rule that everyone has one. No.
Ridley97 asks, do you like to incorporate motivational interviewing in your sessions when or if an issue is clear and maladaptive?
Um, well, that sounds like a particular technique for a particular kind of psychotherapy that I don't do. But I certainly try to motivate my clients to get well by helping them to think about what their goals are and helping them to make choices in terms of is this going to help you to achieve your goal or not?
All right. Benzene asks, have you dealt with people displaying psychopathic behavior? And if so, is it alarming in person or does it have the same effect as any other problem?
Um, I have not worked with a lot of people where psychopathy was their major issue. And again, that's not a population that tends to voluntarily come into therapy. Those are people who tend to be there because they've been mandated to be there because they don't, by definition, don't see themselves as a problem.
Is stress a common theme throughout all the clients you've worked with?
Stress is a part of life, and really, people are stressed about issues that are distressing to them, and that's about therapy is about helping them to cope with that better. But the idea that somehow someone can live a stress-free life, I think, is kind of unrealistic.
Okay. Cecil asks, have you had to deal with physically aggressive clients, and if so, how did you manage?
The only time I had to deal with physically aggressive clients was as a student working with uh, profoundly developmentally disabled people who had significant behavior problems, and then we worked as a team to try and certainly decrease the physical danger and to motivate them to healthier behaviors.
I've definitely noticed, especially among lay people, that there is a huge obsession, I would say, with early psychoanalytic thinkers. So Freud, but also people like Jung and Lacan. Why do you think that is? Especially compared to more, you'd think more modern psychological figures like, say, Beck or whoever.
Because I think that they're more interesting in a way. They're less scientific. They're symbolic. They talk about things like dreams, and I think that people find that really interesting, and what motivates people, what causes them to do things, their traumas and experiences. I think that's what initially drew me into psychology, as those ideas. But I think as for a lot of psychologists, we learn that there are other ways of thinking about things that might be more effective in helping people to deal with their problems.
Um, is it a problem if people look up symptoms of mental illness on the internet and become very worried that they might have something?
Well, it's good for business if they want to come for help, but and it can be helpful if they go to the right sources and they're learning evidence-based treatments and symptoms that help make them more open to therapy and more willing to work on addressing those things with a professional.
Zink asks, have you ever dealt with military vets in your practice and people with combat PTSD in general who return with a completely new personality after war?
I've certainly dealt with you know, military veterans, but typically not people who are experiencing PTSD as part of what's going on with them. Again, that's not my area of expertise, so I would refer them to someone who has that expertise.
Can finding from neuroscience help with therapists' work?
Um, well, neuroscience usually deals with how the brain affects behavior. And so I think that it can certainly um, be helpful because the more we know in generally about how people work, the more effective we can be. But sometimes those uh, ideas require either medication or specific kinds of techniques that the average psychologist or therapist may not be familiar with. Um, so again, I personally don't do a lot of study about that, although I'm always interested in articles that I come across that address those things. But they don't always have a practical application in psychology or anything that I can do anything about.
Okay. A common issue we have in this community is people, and especially young people, coming and seeking help or some sort of mental health advice. And it seems that there's a major um, lack of access to care, especially for young people. What do you think could be done to address that lack of access?
Well, I think that ironically is one of the um, uh, good things that came out of the pandemic, which has made teletherapy much more accessible. I don't think that you lose a lot in terms of doing a video session versus being in the same room with a person. And it can be less expensive because the costs are lower for the clinician, and it allows a particular therapist to work with people from around the state rather than in just their general area. And there are more and more companies that are um, out there that are uh, making that kind of therapy available. So um, that's something to look into is teletherapy if you don't have the means or access to get to see a therapist locally.
Cecil asks, do you sometimes work with people who come from religious or spiritual backgrounds where that aspect of their identity has become relevant to the therapy?
Um, I've dealt with many people who are religious, and we try to work in a way that's sensitive to their beliefs. But sometimes, um, we do question some of the more rigid ideas where trying to live up to a standard that somebody might tell them is not necessarily healthy for the person, and sometimes not really well supported. It may be a belief of a particular clergy person or a particular sect, um, uh, but many times people in a particular sect or religion have their own ideas about what they're, how to live one's life in a way that goes basically along with their belief. And so, I try to help them to achieve their goals, but I don't try to necessarily change their religious beliefs.
Do you take notes during the session, or do you wait until after the session to gather your observations and document them on paper?
I tend to take notes during the session. I find that more efficient, and a lot of times I have people back to back, so I just don't have the luxury of the time to take notes afterwards. Um, but that's I think up to the individual. I mean, I have colleagues who write pages and pages of notes, and others who will write one or two sentences.
Okay. We have a couple people writing questions now. do you have any thoughts on the trends of people who view mental illness in terms of an identity or something to identify as?
Um, I don't know that it's healthy for people to identify themselves as a diagnosis. Um, I think that, and especially as a way to avoid either taking responsibility for their actions or for making their lives better in some way. That's another um, uh, tenet of REBT. That uh, basically, a lot of the things that we like about ourselves or other people, and we call it global evaluations of worth, are behaviors that we or they do or don't do. And behaviors can always change. It may be difficult, but that doesn't mean that it can't happen. And some people do have disorders that are heavily influenced by biology, and they will benefit from the use of medication. But I don't know that it helps anybody to say, well, this is who I am, so there's nothing I can do about it, and you have to accept it.
Um, Benzine asks, what are your thoughts on
Yeah, I'm
persistent?
sorry. Just let me. That's in terms of pathology. Obviously, now we're becoming more aware of gender, and people are who they are, um, and gender, sexuality, and of course, in those cases, I would never encourage somebody to change from that. Um, so but that's different than saying I am a depressed person, and uh, that you have to accept me as that, and I can't do anything to change it. When you can learn to function better. Okay, next question.
Benzine asks, what are your thoughts on persistent procrastination and burnout?
Well, those are two different things, um, and and certainly procrastination is a behavior that people do, that they can learn how to change. Um, Again, not always easy, but that's what therapists are there for, to help people achieve those techniques. And burnout um, is something that certainly can occur in people when they're under stress for long periods of time and unhappy, but it can be helpful for them to learn better frustration tolerance so that they can learn better ways to handle those situations or make changes in their lives that help them to be less burnt out and more enthusiastic and motivated.
All right. Um, are there professional conferences devoted to REBT therapists where practitioners can gather and discuss developments in REBT?
Absolutely. There are many that occur either for continuing education for REBT therapists or therapists in general, and different REBT groups. There's the Albert Ellis Institute um, in New York that runs a lot of them, so that's certainly a good source if somebody's interested.
Is anxiety or depression due to sexual dysfunctions or sexual problems something you sometimes see?
Sure, and it's often though that you know uh, the sexual dysfunction is caused by anxiety or depression rather than the other way around. Because if we say, well, you have a problem that you're depressed about, that sort of implies that you can't do anything to change those sexual dysfunctions. And even people who have organic issues that interfere with their ability to have sex in the way that they think they should have it, in terms of some kind of, if they're heterosexual, some kind of intercourse related experience. The world of sexuality can be much wider. So it's helping people to understand healthy ways that they can express themselves sexually, so that they feel less anxious or depressed.
almost done. It's nearly 10. We have a couple more questions coming in. Um, while we wait up, there we go. Zink asks, do you agree with the sentiment of calling addiction a form of escapism? How correct or misinformed is this?
I think that's a bit of an oversimplification. I think that a lot of people use drugs or alcohol to as a means to cope with issues because they don't want to deal with emotional pain. Um, but there's, there can certainly be a biological element to it, and there could be many other things that motivate it, rather than just trying to escape.
Okay. Ridley97 asks, what would a therapist psychologist who has just become a new parent, becoming a mother or father, do as far as their clients? Given the importance of early childhood attachment and development, they would definitely want to take that time off. However, given the demands of this type of job in establishing therapeutic relationships, what can the therapist do?
Well, it's like anyone else who has a job when they're a new parent. You do your best to manage the responsibilities. It's certainly nice if one has the opportunity to spend more time with their kids, and many people. It's one of the advantages of being an independent professional is that you have a little bit more leeway in deciding how much time you're going to spend with family versus working. But you accept the costs and benefits of that. So, you may forego income, in order to uh, spend time with your family, and which could be well worth that loss to the individual. Or sometimes somebody would feel that you've got to work with your partner to be a good parent. And of course, it depends on the child. There's some kids, you throw them a sandwich every once in a while and they'll grow up to be wonderful, responsible human beings. And there's some kids who, no matter how much of time and effort you devote, they're just going to go in a direction that is not as healthy as it could be. So, I think we all got to do our best with the situation that we have, and that's what life is all about.
Zink asks, how can someone curb internet addiction plus opinions on dopamine detox?
Um, I am not familiar with dopamine detox, and in terms of internet addiction, that's an obsessive behavior, and there's no easy solution. You just do this and it stops. That's why you work with a therapist to find out what's going on that might be leading to that particular behavior, so that an effective strategy can be developed to stop it, or at least
Um,
slow it down.
okay. And Cecil asks, do you think that helicopter parenting is becoming less of a problem nowadays or more of a problem?
Um, I and this is personal opinion. I don't have any research on that, but I think it's becoming um, uh, more of a problem for some people. Uh, I think that you know, people are getting more and more concerned about their children's happiness to a degree that um, they get in the way of helping them to be independent adults. But again, I think that people's parenting styles really vary, and somebody who is an extremely in that helicopter parent phase is probably not all that common um, in the general population.
Um, Zink asks, expanding on this, with the advent of technology and constant monitoring, do you think kids are losing the inherent fun of childhood?
I think it's a different kind of fun. You know, I don't, I think if you grew up when I did, when there was no such thing as computers or consoles, you did certain things because that's what there was to do. Uh, So I think that you know, kids are learning new ways to have fun um, and how to interact with people. You know, they may lose some details sometime, especially when they're not allowed to go to school, that you get when you're directly interacting with a person. But then again, being online can help kids to at least interact with other people um, where they may be isolated. So, technology is a tool, and when it's used in a way that is useful, then people benefit. And if they use it in ways that are unhealthy or harmful, then they don't. But it's working with each other to use these things in a way that is healthy for ourselves and society. That's important, and learning as psychologists, what exactly does that mean, and how do you achieve it? That's kind of the job of the experimental psychologist, is to help to figure out what really is harmful, and what might seem harmful but really doesn't make a difference, and what is actually helpful.
All right, so I think the last question of the night, Benzine asks, some people call depression a hyper-realist disorder, and how you need optimism because reality is depressing in its actual form. Are you in agreement?
I think there's some truth to that, but again, I think it kind of simplifies a complex problem. Um, and um, it's about developing effective ways of thinking that helps you to accept reality, and the fact that the world is not always a great place, but that doesn't mean you can't have a good life. And so that if somebody is focused on all the problems that are going on in the world and they're getting depressed about it, um, then that's just not healthy, and it's not going to uh, make the world a better place. Whereas if we focus on living our best lives possible, and including being aware of other people and their lives and their preferences and their struggles, then it works out better for everyone.
All right. Well, that was 2 hours, so thank you so much for your time. I want to say also thank you to Ridley, Benzine, Zinc, and Fritz, and everyone else who participated and asked questions, because you make the AMA just not me talking for an hour or 2 hours. Um, any final thoughts, Dr. Burstein?
Well, I'd just like to thank everybody for the opportunity. It's been a really interesting evening. And, if you're interested in psychology, go to your library, order a book from Amazon or wherever you like, and study it. Oh, expand your mind, be a lifelong learner.
All right. So I guess we'll end it there. Thanks for coming, everyone. And I guess we don't have any new AMAs coming up, but I'll have it in the events tab when we do.